Hi, everybody, and welcome to the third webinar in our webinar series, Let's Win webinars. And tonight we're going to talk about treatment options for pancreatic cancer. For those of you who don't know me, I'm Cindy Gavin, founding executive director of Let's Win Pancreatic Cancer. Let's Win was born almost 5 years ago as an online platform that connects doctors, patients, and researchers with the latest information on pancreatic cancer treatment options and clinical trials. The site is in English and Spanish, and we have a robust social media community. So I'm so glad that you were able to join us this evening. I want to introduce our moderator, Erica Stallings, who is a dear friend and a fearless advocate for BRCA-related cancers. She has been generous enough to offer her time to lead the three webinars over the last couple of months. So thank you, Erica. And I also want to thank Carla Magruder and Dr. Kim Rice, who have also offered us their time, their generous time to be with us tonight and share their expertise. So without further ado, I will kick it off to Erica.
Well, Cindy, thank you so much for that introduction. As Cindy mentioned, my name is Erica Stallings. I am a lawyer and a BRCA awareness advocate. I learned 6.5 years ago that I carry a BRCA2 gene mutation. In my own experience with undergoing genetic counseling and testing, and learning about some of the disparities that exist in terms of who's affected and access to genetic counseling and testing is why I got involved as an advocate. And I'm really honored to be here this evening for the third of these series because I think that Let's Win just does really incredible work. So pancreatic cancer seems to be everywhere. The disease has taken the lives of prominent Americans and Canadians, including John Lewis, Ruth Bader Ginsburg, and Alex Trebek. And before we get into our discussion this evening, I kind of just wanted to highlight some quick facts about pancreatic cancer. We know that the occurrence of pancreatic cancer is increasing. According to the latest statistics that we have, about 60,000 people are diagnosed with pancreatic cancer each year in the United States. The overall occurrence rate is 12.9%, but it is slightly higher for Black individuals at 15.7%. The 5-year survival rate is low, it's only about 10%. And part of the reason for that is that most people are diagnosed when the disease has progressed to a later stage. The most effective treatment for pancreatic cancer is surgical removal of the pancreas, but often the diagnosis comes too late for surgery to be an option. There's no easy screening test for pancreatic cancer the way that we're able to do, mammograms to detect breast cancer or pap smears to detect cervical cancer. And one thing you should know is about 10% of all pancreatic cancers are what we call familial or hereditary. For all cancers, there are standard treatments based on the stage of the disease, location, based on the stage of the disease or location, among other factors, and pancreatic cancer is no different. However, because of that low survival rate that I mentioned, researchers are continually working on new and better options. And we are lucky that for pancreatic cancer, the standard of treatment is changing. It's really important to have a doctor and a care team that is up to date on the latest research. So we're very lucky this evening to be joined by two really great experts to learn more about how to find the best treatments for pancreatic cancer. We're joined by Dr. Kim Rice, an oncologist at the University of Pennsylvania Abramson Cancer Center, who specializes in gastrointestinal cancers. We are also joined by Carla Magruder, who is a certified genetic counselor at Color, which specializes in medical genetic testing. Carla also works with the All of Us Research Project, a program that is in partnership with the National Institutes of Health to create a diverse health database for medical research. And with that, I'd like to sort of start our discussion this evening with Dr. Rice. And my first question for her is, could you actually explain to our audience what standard of care means, or what we're talking about when we use that phrase?
Yeah, it's a really, really important question. So standard of care, when you think of what the standard of care is for any disease, whether it's pancreas cancer or something different, what you're talking about there is treatments that have been proven and tested and proven to actually benefit patients. So when when we're running a clinical trial, for example, what we're trying to do when we do that is to improve the standard of care. And the standard of care is national guidelines. It's what, if you're being treated by a physician, it's what that physician would turn to outside of, if there were no clinical trial available to treat you. And for pancreatic cancer, the standard of care depends, as you mentioned, very much on what stage people are diagnosed. So the standard of care for currently for curable disease or resectable disease, which you have up there, you say surgery is possible. That's exactly right. If surgery is possible, the standard of care is to operate and then to treat the person with chemotherapy before, after, or before and after. If the illness is caught, or if the pancreas cancer is discovered when the tumor is not operable anymore, which is, as you unfortunately mentioned, is the case for a lot of people that are diagnosed with this disease, then the standard of care is a bit different. It's chemotherapy, it's sometimes targeted therapy. And there's actually, since you have other options up there, I think there's one really important piece to highlight, and that is that standard of care is not only the treatments for a disease. Standard of care includes also testing and things that are done as part of care. And Carla will talk about this more, but essentially, a couple of years ago, we didn't test everybody. We didn't do genetic testing for everybody, or didn't recommend it for everybody with pancreas cancer. And it was discovered that we need to. And now that's part of the standard of care, which means if you're getting good standard care, you are getting genetic testing if you've been diagnosed.
Thank you. And I do want to come back to the genetic testing piece. And I think you started to touch on this a little bit, but how has the standard of care for pancreatic cancer changed since you started seeing pancreatic cancer patients?
It's thankfully changed a lot. It has not changed enough. We'll start with the genetics piece. When I started in practice, we knew that there was a subset of people who developed pancreatic cancer who might have a genetic predisposition variant, some kind of syndrome. And we used to rely on the clinical cues. So if you had somebody in the clinic who had a family history that was very suggestive, or they had a personal history of another cancer, and you thought, it's a little bit strange that somebody's got two cancers in one person, that kind of thing, we would then say, you know what, we think you need genetic testing. And since I've been in practice, the standard of care has changed. And we've learned that if we do it that way, if we only target or ask people to get genetic testing who have a clinical, for whom we're clinically suspicious that there might be something like that, then we actually miss people. Turns out that if you don't do that for everybody, you don't offer it to everybody, that you will miss an important subset of people who could benefit from the genetic counseling, genetic testing. So that's a change. The therapies have changed, like I said, a lot, but not enough. So when I was just starting fellowship, we had, the year before I started fellowship, we had one drug. We had one drug total. We had one chemotherapy for pancreas cancer. And if people were diagnosed, that was the only chemotherapy option that they had. And people died, unfortunately, very rapidly. And in the last decade, from 2011 forward, we've come a long way. We have now several chemotherapy options that are multiple different chemos all mixed together in a combination. And that works a lot better than one chemo alone, as you might imagine. And then we've come to have targeted therapies too. And that includes therapies that are targeted towards genetics. So there's this small group, like you said, I think you said 10%, which is absolutely right, of people who might have a genetic predisposition. And within that group, there's a group of people with BRCA variants or PALB2 variants who benefit from a specific type of drug called a PARP inhibitor. And since I've been in practice, PARP inhibitors have become approved for the treatment of pancreatic cancer. And it's a big step forward. It's not enough. I really want to emphasize that. We are working really hard to try to make it better, because it's still a disease. You showed the statistics. It's really hard to treat and tackle, but we are making some progress.
Got it. And I just want to make sure we kind of hit on this for the audience.
Mm-hmm.
So given these advancements, right, where you're talking about PARP inhibitors, why is it important for pancreatic cancer patients to undergo genetic testing?
So there are two reasons that it's really important. One is that, like we were just, like I just mentioned, it can influence your treatment. So PARP inhibitors is this one class of drugs, they're pills that can be used. They're FDA approved now in the treatment of pancreatic cancer with a BRCA mutation. There are other types of treatments. Actually, some of our chemotherapies, a type of chemo called platinum chemotherapy, is much more effective, or is very effective in people with BRCA pathogenic variant. So it's really helpful for the doctor and for the patient to know upfront, or as soon as possible. So it takes a few weeks, right? It's hard to get this testing sometimes done very quickly, but as soon as possible to know if you have one of these mutated variants or not, because it can potentially influence the treatment. And the other reason that it's really important is for patients' families. So if if I'm diagnosed and I turn out to have a pathogenic BRCA, let's say a BRCA2 variant, and I have children, each of my children have a 50% chance of having that variant as well. And the benefit of getting those, and that's true of any first degree relative, right? So my mother, so anybody who's first degree to me, my siblings. So if I find out that I have a variant and then my kids get tested, if they learn that they don't have it, then they know that they're no increased risk because I have that variant, right? There's no increased risk for this illness. But if they do have it, then they can get into screening programs. They can have maybe prophylactic surgeries. There's a lot of medical care and preventative care that's way better than treating somebody once they're already sick, that we can do for people. So those are the two reasons that it's really, really important. And one of the issues that we come up against is that there's not always access. So this is what you were talking about, a little bit of disparities. There's, it's hard, you need a genetic counselor, you need to be in a place where you can get access to the test and then also to counseling. And so one of the ways that we're trying to address that, because not everybody lives near a big academic center where they have all that available, is to use telemedicine or electronic medicine to try to get people access. So one of the trials that's ongoing that was born at Penn with Dr. Angela Bradbury is called eReach. And basically trying to use a telemedicine platform or a web-based platform to try to make sure that everybody, no matter where they live, no matter how close they are to a genetic counselor, can actually get this care and get this test done if it's applicable to them.
Got it. And kind of just to drive the point home, because I know we may have some pancreatic cancer patients who are listening in, right?
Sure.
So let's say you were diagnosed and you have not had genetic counseling and testing. It sounds like that's something you need to go back and push for to get that information.
Yeah, it's critical, and it doesn't matter, if you have a family history of pancreas cancer or not, or other cancers or not. It's we really learned that we will miss genetic variants if we focus only on the people with some kind of other history. And so if you haven't had that testing, you need to ask your doctor about it. It can change your treatment if it's positive, and it can change your how your family copes with what's going on. It is, though, just to say, a pretty small group. So most people who have pancreatic cancer will not have a genetic syndrome. Okay, most people won't, but there's this 10% that might, and it's not a negligible number. It's not 0.001%. It's 10%. So it's worth. It's an important thing to address with your doctor for sure.
And that does lead me to my one more thing I want to touch on, which is, what does it mean? So let's say, I do have a family history of pancreatic cancer, but I undergo genetic counseling and testing and the results come back negative. What would that mean for me as an individual?
Okay, so there's a couple different scenarios. So one scenario is that you have a relative. So let's say you have a relative who had pancreatic cancer and that person was not tested, right? If you were then tested and you were negative, so in that sense, you don't know, for your other family members should still also get tested. Any first degree relative of the person who had pancreatic cancer, if that person wasn't tested, should be tested. And the reason is that the transmission, the way that these genes work is that not everybody will get the problem. So let's say I have a BRCA2 mutation or variant. I have, but it's not known. And my 3 children get tested. If one gets tested and is negative, it doesn't mean that the other 2 couldn't have it, right? So every first degree, the first point is that it's if the person who has the illness has been tested and was negative, then your children are never going to have it. But because genetic testing is relatively new, it may be that there was a first degree relative who is no longer living or was not tested. And so in that case, it's recommended that every first degree relative of that individual get tested. The other thing is that there's a lot we don't know. So if you have something called familial pancreatic cancer, that's actually not genetically based to a gene that we know yet. So you can have families, if you have 2 first degree relatives with pancreatic cancer or who had pancreatic cancer, and first degree is children, siblings, parents, then you're considered to have familial pancreatic cancer. And that's even in the absence of genetic testing. And so there are recommendations for people who have this familial pancreatic cancer syndrome in their family, again, without a gene, for screening for pancreatic cancer, starting at age 50 or 10 years younger than the person who was affected was when they developed the illness. So it's really important to remember that doctors don't know everything, and we probably don't know most of the genes right now that cause this illness. And so if you have 2 or more relatives with pancreatic cancer who are first degree, you might still qualify for screening either on a clinical trial or for standard of care to make sure that, if you get the illness that they catch it early.
Thank you. And then finally, one kind of a last question before we switch topics is, what is tumor, I have a question, like, what is tumor profiling and how does that impact treatment and standard of care?
Tumor profiling is a little bit different than what we call germline genetic testing. So when we're talking about germline, we're talking about something you could inherit or pass on, right? Something that's in all your cells. And when we do tumor profiling, basically what we do is we take, you had a biopsy, like the person had a biopsy, and we send a little piece of that biopsy tissue off to either a company or one of our own labs, and it undergoes analysis to see if there are any mutations or other things in the tumor that might lead to therapies. So for example, if there's a targeted treatment that's approved, you could find it by doing tumor profiling. And tumor profiling is not done for people who are typically not done for people who have curable or surgically removable cancer, but anybody that is not has metastatic disease or has cancer that can't be removed surgically, we recommend this tumor profiling. It is a little different than germline because those cells used to be your own cells, right? They used to be human, regular parts of the pancreas, right? So they have, theoretically, they have whatever variants all of your cells have. So you could find a BRCA mutation, for example, in a tumor. But those tumor cells have also undergone evolution, some kind of change to become cancer cells. And so if you can also find mutations or variants that are not inherited, but still might have treatment implications. So that's why it's really important to do that. And if your tumor profiling shows a variant like BRCA2, you don't know from the profiling whether that's just in the tumor, because that's possible, or whether it's actually in all your cells. And so that then should also trigger a genetic evaluation if something like that is found, if genetic testing hasn't already been done.
Got it. Thank you so much. Mm-hmm. And with that, I'd like to switch over to our genetic counselor, Carla Magruder. So as I was discussing, research has shown that patients that carry certain mutations, such as BRCA1 and 2 mutations, PALB2, respond better to particular treatments. And as we've just learned, genetic testing is now a part of the standard of care for pancreatic cancer. And now we'll be joined by Carla Magruder, who will explain to us, or we'll have a discussion on how patients can actually access genetic counseling and testing.
Yeah, so thank you for having me here this evening. Certainly, anytime I talk about being a genetic counselor, people go, okay, great. And they kind of mumble, what is that? What exactly do you do? So it's no surprise that a lot of people don't even know really what genetic testing is, or that it's recommended that you go through a genetic counselor to get it. And certainly, like we've been talking about with pancreatic cancer, it's something where I think anytime we hear a diagnosis, the world kind of stops for a second because we all have heard stories or we want to know things. And certainly the second question beyond that being that initial diagnosis of pancreatic cancer is, why did this happen? That why question is what genetic counselors deal with. And like we said before, most cancer is not hereditary, meaning it's not passed down in the family. Most things we don't know. We're not that smart yet. We're still trying to figure it out. But there's 10% of all these pancreatic cancers that we can point to an actual answer and go, this is something that actually increase your risk for cancer. We don't have anything that's going to tell you you're going to be 100% gonna get a cancer, but genes can tell us if you're just born with an increased risk that would lead to you having a more susceptibility of having pancreatic cancer. And so genetic counselors, we work with oncology teams. You can see us either when you have a diagnosis, so like Dr. Rice talked about, getting testing as someone who is in the middle of treatment to actually guide your treatment. And there's genetic testing where you can send it rapidly and get the result back in about a week if you're planning a surgery around that. You can get it genetic testing and genetic counseling after you've had a diagnosis. So sometimes people go, oh, I'm not in active treatment. No. For a lot of people, this genetic testing wasn't even available for them when they actually had the cancer. So if you have a personal history of cancer, you can also see genetic testing. And then finally, if you just have a family history of pancreatic cancer, so you yourself have not had it, but family history, those are all different indications of why you would see a genetic counselor. What we do is we look at your family history and your medical history, put all that together, and first figure out what testing you should have done. And then from there, kind of give you an expectation of here's what you can expect. I think there's a 3% chance you have a mutation, or hey, there's about a 15% chance we're going to find something here. It's some guidance of what to do. Genetic counselors also talk to you about insurance, how it's going to affect your health insurance, your life insurance. And sometimes people come in and they will come in maybe on the anniversary of a diagnosis, or maybe on the anniversary of a loved one who's passed away, or on the anniversary of, hey, my mom got this when she was 42, I'm 41, I'm starting to really think about it. And you may not know if you even want to know if you have a gene that's causing this. And so that's where that counseling part comes in, because we talk through all that. And since we are talking about family history, Dr. Rice mentioned first degree relatives. Those are your parents, your siblings, and your children. We also talk about second degree relatives, your aunts, your cousin, your grandparents. Third degree relatives, your nieces and nephews are second degree, but cousins. We talk about a lot of family. And we all know that families can get kind of crazy. Families can get kind of sensitive. Families can get to a place where you may say, I don't know that side of the family because we don't talk, and it could be some trauma there. We talk about it all. And we talk about that so that we can get to the point of trying to figure out what's the best testing for you. Certainly the BRCA, or what they're called as BRCA genes, can account for pancreatic cancer, but there are other genes as well. And I can't tell you how many times people have come in for a history of breast cancer in the family, and they know about the BRCA genes for that. And then if we do find a BRCA mutation, once we talk about breast and ovaries, then we say, oh, and there's an increased risk for pancreatic cancer. They go, wait, what? There's a lot to understand. And or people come in thinking it's going to be BRCA, and it's actually a completely different condition that leads to an increased risk of pancreatic cancer, colon cancer, and uterine cancer, pancreatic cancer, and melanoma. Like, it really depends on which gene that we're finding these mutations in, not only what other cancers we're worried about, but what is the actual increased risk of pancreatic cancer? Are we talking about an increase of 3% more or 15% more? Which is then going to guide how often we're going to screen people who haven't had pancreatic cancer. Am I recommending you start screening at 50, at 40, at 35? These are all different questions that genetic counselors help guide this situation. And physicians, doctors have so much on their plate, they may not be up to date with everything. The guidelines actually just changed again in February of this year. And so genetic counselors, we are the gene experts, although if you let my husband tell it, we're the gene nerds. I don't care, I'll take all of those titles, but we're here to guide you through what's the most recent update with screening, with guidelines, and with who meets criteria for testing. Even if it's a grandmother who's had pancreatic cancer, there are actually guidelines where you can meet criteria for genetic testing. And when we say meet criteria, we talk about cost, we talk about those different ways, because there are disparities where not everyone has the time to go to a doctor's office and pay for testing or go through a pre-auth. Not everybody even has insurance. There are other ways that you can order testing and have a kit sent to you and pay out of pocket of $200, $300, or if they found a gene mutation, as low as $50 if somebody else in the family already has a gene mutation, so that you can get testing done. So having a family history of cancer, having a personal history of cancer would be why you would see a genetic counselor. There's different genes that can tell us different things about, is it just pancreatic cancer that we're concerned with, or are we worried about other cancer conditions? And very much so important for people to talk to their families. It can be difficult. Certainly in previous generations, you just didn't talk about those things. It was taboo, or you didn't speak it into existence. So you might know that someone died very young, but no one really talked about why. Talk about those things. Or if you have pancreatic cancer, tell your kids, tell your family what type of pancreatic cancer you talked about. If that's a neuroendocrine pancreatic cancer caused more by hormones, grows more slowly, that doesn't meet the same criteria, and we're not as concerned as if it's the adenocarcinoma, the one that we know is much more aggressive. All these things are very helpful when you're talking to a genetic counselor, and I'm very thankful that we have many more ways to do that, to reach out to people beyond just the clinic setting.
Yeah, so one of the things you talked about getting a kit sent to you is, what's the difference? What is medical genetic testing, and how might that be different from consumer testing? Or let me say it another way. Is the 20, like if you do 23andMe or Ancestry, is that the same as this medical genetic testing that we're talking about this evening?
It is not, that's like saying, well, is, going to McDonald's the same as going to Ruth Steakhouse or something? No, it's not different. The McRib there is very different than whatever rib you're going to get. 23andMe is an amazing test for if you want to know where you've come from, where your ancestry has come from. And if you're curious about the other questions they may ask you about. I think sometimes they ask you about, or tell you about your favorite wine. They might even tell you that you have an increased risk for arthritis or other medical conditions. But the medical condition part is not something that we use in clinical settings. Meaning, and I know a lot of people already know, if you take your 23andMe results to your doctor and say, here, they can't act on that because it's the technology that they use isn't something that is sophisticated enough to look at everything. I think about a few years ago, maybe 4 years ago now, they came out with BRCA testing, where they test for the 3 most common mutations that we see for people who have Ashkenazi Jewish ancestry, a very specific type of ancestry. And so people will say, because they've seen the BRCA result is negative on the report, oh, I had negative BRCA testing. You did not. They tested 3 specific mutations on 2 strands of DNA where there's thousands of different combinations of what mutations can be. So it's not complete testing. And it doesn't mean quite a whole lot if you don't have Ashkenazi Jewish ancestry. And even if you do, and they find that one of those mutations on the 23andMe, that you have one of these 3 mutations, if you take that to the doctor, they're not going to do a surgery on that or do anything else, because the recommendation, even from 23andMe, is to have that confirmed with the clinical grade test. So unfortunately, if you do 23andMe just for the BRCA results, you're going to pay for that test twice. So I always want to make sure that people know that. The clinical grade test is differently because it doesn't just look at 3 places or look at little small changes that may be common. It looks at big changes, small changes, goes backwards and forwards with thousands of reads, meaning a computer goes through those same DNA sequences thousands of times to see if there is a mutation there. And generally the testing that you're going to see with the clinical grade, again, doesn't just look at the BRCA genes, it looks at multiple genes and what we call a panel of testing. And by the way, for people who might have had testing years ago, you might have just had the BRCA1 and BRCA2 gene done and that's it. But that was before we knew about other genes. So you can always go back for an upgrade of genetic testing. So the testing I'm talking about, Erica, is that clinical grade test where you can go, and it used to be on Amazon, not anymore, but there are other laboratories, Color Genomics is one that I work for, and Vitae is another one. And again, there are several others where you can go in to this clinical website, order a test. You will still talk to a doctor or still have a doctor sign off on your report, and then still have access to genetic counselors through that. But you get to get sent a saliva kit with saliva and blood. They're going to give us the same thing. It's still DNA. So sometimes people wonder, is saliva as accurate as blood? The blood sample, the DNA in that sample, it's easier for us to get. So sometimes the saliva sample might fail just because we don't get enough DNA out of that. But either way, you can then do your thing, spit in the tube, send it off without having to go to a doctor's office, and it'll come back to the lab secure, and you can get a DNA result that way. But that's a clinical grade test. That is not the same as 23andMe. I love 23andMe to tell us where we come from, who you may be related to, not to tell me if I have an increased risk for cancer. I hope someday that they will be able to do that, so it can be even more expensive for everyone, more cheaper for everyone, but that's just not where we are.
Got it. And so one thing you also touched on, you talked about the fact that 23andMe is only testing for 3 variants that are in the Ashkenazi Jewish community. And are there any particular populations or people of certain heritages more at risk for carrying these genetic mutations that we've been talking about this evening?
That is so amazing. And the answer to that is there are, and we are still figuring it out. So there are numerous people who will say, well, I was going to do the testing, but I talked to my friend or I talked to, a nurse, and they told me that I'm not Ashkenazi Jewish, so I don't have an increased risk for that. And it's because, for great reason, that community has been advocating so much for BRCA testing, because there is a higher occurrence of having a mutation in those genes, which could increase the risk of cancer. And we know that. So if we know that, we want to make sure that other people know that as well. And it's great they've been advocating for that. However, we're also finding out that in the African American community that we're seeing a higher rate of the BRCA mutations that we didn't know about. And so that's another thing. A genetic counselor may ask you where you're from, where your family's from. And it's not just, because we want to get that up into your business, or we think that we know somebody that, is in your family. It's because knowing the ethnicity can help us understand a little bit of how concerned we may be. That's also a great thing with the All of Us research project. So that's a project that I'm a senior genetic counselor for, partnered with the NIH. And it's because with those disparities and with medicine now, most of the genomic data, all the research that we're looking at, everything that we're comparing DNA sequences to say what is normal, what's not normal, is generally based on Northern European genome sets, because that's who historically has been in research. With the All of Us research program, what we're doing is trying to sequence 1 million genomes of people from underrepresented areas. And that's not just based on, if you're Black, if you're brown, but also, are you in a rural area? Are you a first generation, college student? Are you from the LGBTQ community? People who we see generally that we're not capturing enough by a long shot. We're trying to get all those people in so that we can get all that data. And I can tell you now, Erica, that we're already starting to see that some populations or some people that we didn't thought maybe would not be as much affected, we're seeing very different stories, because we're still gathering research about, when we're getting all this information from people that we don't know about, is there a higher occurrence of these mutations happening?
Yeah. You also touched on this when you were giving that really great overview. You said a genetic counselor can, help you figure out the insurance part of accessing genetic counseling. But I guess 2 really quick questions. Does insurance cover genetic testing? And then if you undergo genetic testing, can that impact your insurance status?
Yes, so the answer is it doesn't cover it for everyone, but it does if you qualify. So if you hear us say you may qualify or you may meet criteria, it's because we're running through all these different checklists in our head of if there's someone who their risk for having some genetic mutation is going to be enough where insurance covers it. And that generally is, if you have pancreatic cancer or have a history of it, yes. You meet criteria. Pancreatic standing insurance is going to cover it, right? If you have a close relative, meaning a mother, a father, a parent, a sibling, or a child who has had pancreatic cancer, or even a second-degree relative, a grandparent, or a niece or nephew, aunt or uncle who has had pancreatic cancer, yes, you're going to meet criteria. And then there are some insurances that take it even further than that to the third degree. Did you have a grandparent? Did you have, a cousin, whatever? Those are all things that we look at. If you have someone who's had pancreatic cancer that is close to you, or if there's pancreatic cancer and another cancer like breast cancer, ovarian cancer, anything else, it's not just pancreatic cancer, you can still meet criteria where your insurance will cover that. Now, that does depend on your deductible, which is why some people choose to do a cash route and maybe do testing from a different carrier, because luckily we have different companies and laboratories that do this type of testing. But it still depends on your deductible, but insurance will still offer coverage, saying, yes, you meet criteria. If you have a lung cancer and a 70-year-old person, and then a cousin 3 times removed that you met at a family reunion a few years ago told you that she might have had a basal cell carcinoma, you're probably not going to meet testing criteria for this. And it's because those relatives are distantly removed, or the ages of those cancers are old enough where we say that cancer probably happened by chance or some other reason. So no, insurance isn't going to cover it. And I will say that there are some providers that are protective of their patients. And because they might have seen one insurance not cover it, they may say, I'm not going to order this for anyone because it just doesn't work. You're going to get a huge bill, and that's not true. You can always send in for pre-authorization to first know how much you're going to owe and get an estimate of that. And I do want to say with Medicare is different. They're changing, but we all know that Medicare changes slow. Where generally with Medicare, you have to actually have had a diagnosis of cancer in order to qualify. It's not enough to have a brother who had pancreatic cancer, but you haven't had any cancer. Medicare's idea is if you've reached Medicare age and you haven't had a cancer, chances are you don't have an increased risk for cancer, because we would have seen that cancer happen at a younger age. That's their rationale. You can go back and forth with them. And again, there are always options if they won't cover it, where sometimes a laboratory will cover that depending on what their contract is. That's health insurance. Health insurance also, if you have a mutation, will not drop you from your insurance or change your rate because you have a mutation. There are laws that have been in place, certainly with the Affordable Care Act, but also go back to the Bush era with other laws that were passed in 2008 to protect you so that it's not considered a pre-existing condition at this point. If we ever go back down that road of pre-existing conditions, there's a whole different law beyond the Affordable Care Act that have to be addressed that had protections built in already. The Affordable Care Act just came in and bolstered all of that. So your health insurance doesn't even ask for this inpatient. So it's not going to get dropped and it's not going to change your rate. Life insurance is different. Life insurance can ask you about genetic testing information and can choose not to cover you if that's the case. So sometimes people will say, you know what, let me wait, let me get my life insurance, I'm together, or I'm getting ready to change the beneficiary, let me get it settled. And then once I have it in place, then I'll come back and do this genetic testing. Life insurance doesn't have time to come and audit you after 3 years and go, hey, have you thought about genetic testing? Let's see. So, you can get the life insurance and be fine. And they rarely ask for that information again if you're going to re-up or change your beneficiary. But I always want to make sure that people know that. Health insurance, you're protected. They don't even ask for this information. Life insurance may choose to do that, and you're not protected with that. So you want to make sure you're taking all these things in consideration with testing.
Got it. That was so informative. I do want to make sure we leave some time for a Q&A. So I want to bring back Dr. Rice very quickly, just to talk a little bit about clinical trials and why they are so, well, actually, my teeing up is the question, which is, why is participating in clinical trials so important? I guess 2 parts. Why is it important for patients to participate in clinical trials? And then how can patients find clinical trials to participate in?
Oh my God, such a good question. So clinical trials, you asked before about what's standard of care, right? What is standard of care? Everything that is standard of care was once a clinical trial, right? That's how we learn. That's how we improve what we can do for people. And that is what clinical trials are for any cancer, specifically for pancreatic cancer. If there is a clinical trial available to you, what those physicians are trying to do, what those researchers are doing, is trying to advance the field. So if some of them are based in genetics. So some clinical trials are specifically for people with one mutation, one variant or another. But there are a lot of clinical trials that are just for people with pancreatic cancer as a diagnosis, and trials come for all different stages of disease. So pre-surgery, after surgery, trials for people who are not curable. There's trials for almost every stage. How to find those trials is often kind of a maze for people who are diagnosed, and it's difficult. There are two places that I can recommend. So you got to get on the internet. If you can, and if not, talk to your oncologist who can get on the internet for you and can kind of interpret things. But there are two places that are really good to look. So one is actually Let's Win PC, right? The site that we're on right now. They try very hard to keep, and they do a wonderful job of keeping ahead of the science that's happening. And so they post interesting science. They have a whole section for interesting science and upcoming things where you can look. For something more specific, PanCAN, the Pancreatic Cancer Action Network, has its own clinical trials finder, and they try to just look, they only do clinical trial finding for pancreatic cancer, not for all cancers. So it's a little bit focused on what you might need. And you can also call them and they will run through the list for you. So it's another disparity issue. All trials aren't everywhere. Some trials are only available in California or in New Mexico or, in one state or another. But please do look, as the goal is to try to hopefully offer you something better than we currently have. So that's, and I forgot the second, did I answer both questions, Erica? I forgot.
No, you did.
Okay, good.
So, well, with that, because we have such wonderful experts with us, I do want to make sure we do have some time for Q&A. So if you're listening in, please put your questions into the chat function here on Zoom, and we will try to get to as many questions as possible. One of the first questions I want to ask, which we talked a lot about genetic counseling, is actually how do you access, how do you find a genetic counselor? How do you access this testing?
Who do you want to have take it?
Well, either or both. I'm sure you both have valuable insight on this.
Carly, you want to take it? Go ahead.
Yeah, so for genetic testing, the way you can do that is actually going to findageneticcounselor.com or nsgc.com, National Society of Genetic Counselor. But just typing in your Google genetic counselor, you will get the findagc.com option there. And that's especially important because, again, we aren't everywhere. So if you're in a city that's lucky enough to have us, you may say, oh, I found a genetic counselor. And then when you call to schedule an appointment, it may be a long wait list, or may, again, just be during times that don't fit with your schedule. And so that's why you also have the option to have genetic counseling online as well. So there are places that do that, like Inform DNA, and other places where they will talk to you before you've had a test or after you had a test to make sure that you still get the guidance. But generally, find a GC, it can be shortened that way, .com, findageneticcounselor.com is the best way to find a genetic counselor to talk to. And certainly just talk to your doctor and see if they know about genetic testing options. Also, those things are going to be the best way to go.
Thank you. I think, Dr. Rice, this is for you. I'd like to know more about the liquid biopsy testing, such as Guardant 360, and the limitations of the findings, i.e. what could it miss?
That is a fabulous question. So Guardant 360, and there are more than one platform like them, but we'll use them as an example since you mentioned them. Those are what we call, like you said, a liquid biopsy. So what you're doing there is you're taking a sample of blood and you're looking for circulating DNA from a tumor. So tumors, just like most cells, will shed as they die. They open up and they shed their DNA into the bloodstream. So you can capture that on a liquid test and look for specific variants. Tests like Guardant 360 are a little bit limited. The technology for those liquid biopsy tests is just a little bit behind where the knowledge is for the tissue tests. So if you get a tissue test, one from a biopsy, you may get 500-600 genes that are looked at, and you might get other things that are looked at, like PD-L1 status and other things in your tumor. The Guardant test and Foundation one has one, Foundation Liquid, and there's one coming from Caris testing as well. Their technology just isn't exactly the same. So how do we use them? Why do we use them, right? So we use those tests when the tissue is insufficient. So if you had a biopsy and they send the biopsy off for that testing that we talked about before, and it comes back and the lab says, look, there just isn't enough DNA, there's not enough tumors out there, we don't have enough tumor cells to make a diagnosis there, we can't process it and give you the test, then the physician, if they can't get a separate biopsy, that's a discussion with the patient and doctor about how to do that. But sometimes if there's no option for tissue, we will revert to, or we will choose as a backup option, one of these liquid biopsy tests. So they can miss, they just miss things because they're much smaller panels. And as we go, down the road, as testing and DNA analysis and RNA analysis and protein analysis gets better and cheaper and faster, those tests will eventually catch up, but we're just not quite there yet.
Got it. These next two questions are also for you, Dr. Rice. First one, should you assume a BRCA variant isn't the cause of your cancer if your disease progressed on, and I hope I say this correctly, FOLFIRINOX? FOLFIRINOX.
That is a very sophisticated question. So let me start with one thing. So first of all, variant, a mutation, of variant, we now call them variants, but mutations are variants. They come in two different flavors, or actually three different flavors. So there are ones that are benign, which means you might have a change in your DNA and it might be meaningless. It might do nothing to the cell. It might just be a passenger. And I could have a BRCA variant that is a benign variant. That means that the change doesn't alter the protein the BRCA protein, let's say. So a benign variant. Then there are variants that are pathogenic. Those are the ones that we say they increase your risk for cancer. Those are the ones we worry about. Those are the ones that will respond to specific therapies potentially. And then there's variants of uncertain significance, which are ones we don't know which bucket they fall into. We're just not smart enough yet to know which bucket. So the first part of the question is, should you assume it isn't part of your cancer if your cancer progressed on a platinum-based therapy, which is what FOLFIRINOX is. And usually BRCA-related cancers are sensitive to platinum. And it's a complicated question. So first, make sure it's a pathogenic variant, because a VUS, variant of uncertain significance, or benign variant are maybe not at all related to the malignancy, or may have no influence on the response to FOLFIRINOX. That said, not all BRCA, let's say it's a pathogenic variant, it's a germline variant, meaning it's an inherited variant, and the cancer does not respond to FOLFIRINOX. We know now, nothing is absolute, and we've always known nothing is absolute in medicine, but nothing is absolute in terms of this either. So there is a small group of people who have a germline variant in BRCA and a pancreatic cancer, and the two are actually unrelated, or one doesn't influence the other. And so, we call that in medicine true and unrelated. You have the variant, you have the cancer, but it turned out they weren't together. And so those patients or people in that situation, their cancer would behave like a sporadic cancer, meaning it would respond or not respond. And then the last thing I want to say about it is that if it's an incurable pancreatic cancer and it's treated with FOLFIRINOX, some cancers, even if they are BRCA related and they should respond, they will respond for a period of time, but cancers eventually, if they're not removed surgically, will find a way around the treatment. So you could be treated for 6 months, a year, 2 years, like whatever the time period is, it doesn't matter, time period, with a drug that works, but then eventually fail it. And that doesn't mean that your cancer wasn't related to that genetics.
That was very informative. And then the second sort of a follow-up question to that is, would you ever prescribe a PARP inhibitor off-label to a patient with a BRCA mutation if the patient failed platinum-based chemotherapy?
Another very sophisticated, good question. So you're talking about outside the POLO data, which was the data that made olaparib Lynparza approved for pancreatic cancer. Those patients who were on that trial were all what we call platinum sensitive, which means their cancer was responding. It's not that I wouldn't ever consider it, but generally, biologically, once a cancer with BRCA has found its way around a platinum, in other words, if it has had platinum, FOLFIRINOX, cisplatin, or oxaliplatin, and then has grown through it, usually those cancers are unfortunately then also resistant to PARP inhibitors, meaning they won't respond to PARP. It's not that it's a never, again, nothing's absolute. It's not a never. If there were no other options, I would probably have that discussion with the patient, but I would be concerned that it wouldn't work.
Thank you so much. And then actually, Carla, I'll throw the last question to you. At the beginning of the presentation, the slide said the average rate of pancreatic occurrence in the US is 12.9%. Please explain.
Yeah, so the risks that I generally give are more of the absolute risks. So when we're looking at pancreatic cancer overall, it's actually about 1 out of every 64 people is what we see with pancreatic cancer. So when I'm talking to patients, we're talking about there being a 1 to 2% risk of that. Now we can break it down into when people are actually diagnosed at what stage to get different numbers when you're talking about the occurrence rate, but generally I still quote a much lower rate of 1 to 2%, and then having a genetic mutation can increase that to up to 15%, depending on which gene that we're talking about. There's not really any genes that increase it beyond that. And then certainly, you know, I always want to make sure we talk about that, because sometimes when you get a genetic mutation and you see this big number that says you have a 15% risk for pancreatic cancer, we have to also break down that is your lifetime risk. So that's if we count it up to age 80 over your entire life, there's a 15% risk or 10%, 12% risk of that cancer. But as you're sitting here and talking to me now, that risk may be at 2%, 3%, 4% for your age group. So we always want to always put it in perspective, because that's going to help people understand how concerned they should be or what decisions that they want to make going forward. So there's always going to be these different numbers, but generally when we're talking about pancreatic cancer, the chance that we're going to get it, you'll see less than 1% to 2% on the high end, depending on who you're talking to. And then if there's an increased risk for cancer, you'll see anywhere from 3 to 15% based on the family history, and also based on if there's a gene. And I do want to say, someone said that in the chat that their 23andMe found their trait for blood clot, which is great. I don't know if that was factor 5 like mutation, but again, 23andMe looks at common, or again, common if you're Northern European, common traits. So it's still looking at 5 different places that they see, or 10 different places in one gene that you may see as a hotspot, or something where you will see in a lot of population of people, but it's not going to look at the entirety of the gene and be a complete testing. So I'm always happy when someone can find something in a test like that and then confirm it somewhere else. So happy that that's been found always, but still saying why it's not complete to make that distinction. Good questions.
Thank you for that. So those were the questions that we have. And so I would say first, thank you to the audience, or everyone who's listening, for being here and asking such great questions. And then again, just thank you, Dr. Reyes, and to Carla, just for sharing your expertise with this group. And just some really quick closing thoughts. I think, as we've all learned this evening, treatment for pancreatic cancer is constantly evolving as, you know, researchers and genetic counselors and oncologists look for better options. And genetic testing, it has proven to be a key piece of information for many people, you know, both in treating pancreatic cancer and then knowing if you're at a higher risk for pancreatic cancer. For more information, please visit the Let's Win website. And the recording and the slides, as well as the links that you see here, will be sent out to all of the attendees. So just thank you again to Les Win for giving me the opportunity to moderate this series.
Great. Thank you, Erica. You have been incredible, and we're so fortunate to have you on our team. To Carla and Dr. Rice, that was such a wonderful update. It was so informative, and we really, really appreciate you taking the time this evening. We want to thank everyone for participating. As Erica shared, we're going to be sending out links. We hope that you will share them. And finally, I just want to a special thanks to AstraZeneca. None of this would have been possible without their support. So thank you all. I hope you have a good evening and stay safe, and we hope to see you soon. Good night.